Excellencies, distinguished guests, ladies and gentlemen, good morning, good afternoon, and good evening. It's a pleasure to welcome you to this first World Obesity Federation webinar on obesity in Africa. The inspiration for this came from the recognition that while on the one hand, many countries have rates of obesity that are growing very rapidly across the African continent, yet what we know about the main drivers and possible solutions is still quite sketchy, and most African countries have been neglected in terms of research and resources. While on many levels, obesity drivers and solutions are the same everywhere, there are distinct characteristics that differ by geography. And even within the African continent, there are many differences and a variety and range of experiences around this. Even in the food space, despite overweight and obesity occurring in many cases in the same countries and even communities and families as stunting and general issues related to undernutrition, we sense that there's a missed opportunity to really incorporate, have double duty solutions around obesity and underweight and undernutrition. We do not pretend to have all the answers, and we are here to listen to a group of brilliant and experienced professionals, government leaders, healthcare professionals, advocates, and patients who are going to share their own experiences. And through that, we hope to get to a better understanding and some common solutions. We also know that there are many roots to obesity: unhealthy food, genetics, mental health challenges, biology, maternal status, and that like many non-communicable diseases, the solutions are also equally as complex, and there is no one simple solution. Therefore, the World Obesity Federation and many of our colleagues came up with an acronym for the solutions that include the word ROOTS: recognizing obesity as a disease and a risk factor, obesity through the life course, obesity monitoring and surveillance, T for treatment and training, and S for systems. And we believe that it's through a combination of all of those: healthcare, prevention, measurement, common agendas, we can find a way to help start to do a better job of addressing the challenges of obesity in Africa. A couple of housekeeping points. We have a strong preference for people first language, which means, again, identifying a person first rather than the condition or disease. So we prefer when people say person with obesity rather than obese person. It really emphasizes the humanity of the individual living with this very challenging disease. So thank you for keeping to that. Also, the webinar is being recorded, and please use the Q&A function to post comments and questions. The recording, slides, and certificate of attendance will be circulated post-webinar. Now, it is my great pleasure to introduce our first speaker, Professor Carol LaRue. Professor Carol LaRue graduated from medical school in Pretoria and completed his specialist training in metabolic medicine at St. Bartholomew's Hospitals and Hammersmith Hospitals. He obtained his PhD from Imperial College in London and is now based at University College Dublin, where he's chair in experimental pathology and director of the metabolic medicine group. He is a leader in Europe and across the world, but it is very clear when you speak to Professor LaRue that his heart truly lies in Africa, and I think he's very pleased to be here as well today. So, Carol.
Thank you very much for that wonderful introduction. If I could please have the next slide, please. So really thinking about obesity, and I'm showing my conflicts of interest here, we are unlikely to find one silver bullet, because this is unlikely to be only one disease. And therefore, we need multiple treatments, both diet approaches, exercise, medications, and surgical approaches. Next slide. And what we can see with obesity in Africa is that there's a large variation in the prevalence at the moment, but that all of Africa is being affected by this disease. Next slide. We also see that specifically our children in Africa are at very high risk, and we're seeing incidence numbers that's very similar to the worst places in the world that is being affected. So what we are seeing is our young people are catching up first when it comes to obesity, and therefore our future is really at risk. Next slide. And this is, of course, happening in conjunction with malnutrition in Africa still being a challenge. So we have these two problems occurring at the same time, and that really leads to quite a lot of conflict, even internal conflict, when we are thinking about how we would think about food and promoting healthy eating. Because on one side, a large section of society who live in significant poverty may not have enough food, while another section of society who also live in poverty may only be able to eat foods that is driving the epidemic of obesity. So these are maybe not unique challenges, but significant challenges within our continent. Next slide. So we're asking ourselves the question, is obesity a disease? Because we as healthcare professionals are very good at treating chronic diseases. And especially in Africa, we have specific skill sets when it comes to dealing with chronic diseases that have afflicted our continent. Next slide. And yes, the World Health Organization and many other organizations have declared obesity a disease. But just because people vote to say that obesity is a disease, or we have a consensus that it is a disease, does not mean that we treat it like a disease. And more importantly, it does not mean that people who are suffering with obesity actually think of this as a disease. So I'm going to challenge you around this webinar just to think about this for a moment and how this pertains to our patients and across all of Africa, and how we can communicate these ideas, because I think this is the key that can unlock our treatment options. First of all, for us to understand that this is a chronic disease that needs chronic treatment. Next slide. So we are very familiar with the complications of obesity. And when we teach medical students, we ask them about the complications of obesity. And there's more than 200 different complications. And I remember when I was at medical school, my professors telling me that if you know syphilis, you know medicine, because it affected all the systems within the human body. And now it is really, if you know obesity, you know medicine, because all of the systems are affected, and therefore all of healthcare professionals across the board are interacting with the complications of this disease. And yes, what we want to do is prevent the complications of obesity. Next slide. But what we also want to do, and what good healthcare professionals across the world will do, is they will also address the symptoms of this disease. Next slide. And this is a famous painting that hangs in the Prado Museum in Madrid of this young girl in the 17th century that was found in the countryside in Spain, brought to the Spanish court because she weighed more than 70 kilograms at the age of 6. Now, I put this painting up because it shows you that the stigma of obesity is not new. People have been pointing fingers and being really intrigued by people with severe obesity for many years. But what we are now also thinking is if this young girl comes to your clinic tomorrow, her mother will ask you, please help me because my child is hungry all the time. And I think this is the first symptom that we need to recognize from obesity. The second one is when the mother will say, please, doctor, when the child starts eating, the child cannot stop. She has to consume a large amount of calories before she feels satisfied. So if we now think about where these symptoms are generated, next slide, then I think we will agree that most of this is generated by neurons. But then we have to ask ourselves the question, which part of the brain code for hunger and code for satiety? Because that will allow us to target the organ that is responsible for this disease of obesity. Next slide. And when we look at gene-wide association studies, we see that more than 80% of the genes responsible for obesity across the world, doesn't matter which populations we look into, points to the central nervous system. Next slide. And if we dive into the central nervous system, I'm highlighting the hypothalamus here, but it's really the subcortical areas of the brain. It's the nucleus tractus solitarius, the area postrema, the amygdala. These are all neurological centers within the subcortex that you and I cannot control by thinking. So none of us around this webinar and none of our patients that suffer with obesity can think themselves less hungry or think themselves more satisfied. And therefore, it allows us to have sympathy with our patients who are really struggling from this neurological disease. And therefore, it also helps us when we are coming up with strategies, be it environmental strategies, system-wise strategies, or even treatment strategies for the individual, that we know what we need to do. We need to alleviate the symptoms of obesity first, and then what we have to do is prevent the complications. Next slide. So, because when we do that, be it through diet approaches, medication, or surgical approaches, what we hear our patients tell us when we are successful is they say, you know, this treatment that you've given me is so easy because for the first time in my life, I'm not feeling hungry. And when I eat, I feel satisfied. And suddenly my behaviors have become natural. I'm not even trying, to be a good citizen. But what I'm just doing is living my life normally. And so many of our patients come back to us and say, all I want to be is normal. I don't want to go through the entire day thinking about food every minute of the day. I just want to be relieved from this burden. And I think with our better treatment strategies and prevention strategies, we will be able to do this within the continent of Africa. Next slide. So I'm going to summarize and say that obesity, wherever you are, but certainly also true within Africa, is a complex and chronic disease, most likely of the subcortical areas of the brain. It's characterized by excess adipose tissue that causes disease. And these are the complications that we are interested in, the causing disease. And the excess adipose tissues are the signs of the disease that you and I see when we examine our patients. But very importantly, addressing the stigma may be the single most effective strategy at this time to allow people to understand that this is a disease that needs chronic treatment and it's a disease that we can address. Next slide. Please allow me to thank the team at home that's doing all the hard work. And next slide. Also to thank our international collaborators. So that's the end of my presentation, and I'm handing back to Johanna. Thank you.
I just have one question. So first of all, thank you very much for that excellent presentation. And just one question. I think we, within the Roots framework, we really frame obesity as risk factor and disease, like diabetes. And I just wanted to clarify, I think you've done a fantastic job of confirming the disease state, but do you agree with that larger definition, broader definition?
So I think many other diseases, for example, type 2 diabetes is a disease in its own right. But of course, people don't die from hyperglycemia. They die from the complications of diabetes, for example, such as nephropathy or neuropathy or macrovascular complications, heart attacks and strokes. And I think if we can frame obesity as a disease, but also it is a malignant disease. It's a disease that has more than 200 complications. So you can view it from different sides. So if you are, for example, a respiratory physician and you treat sleep apnea, you will view obesity as a risk factor for your sleep apnea. And I understand that, and I think that's perfectly valid. But I do think that we should frame obesity as a disease and understand the complications of this disease. And one of the challenges that we have is, of course, not everybody that has the disease of obesity develops type 2 diabetes, or not everybody develops osteoarthritis. So we are just not clever enough yet to predict which patients with obesity will go on to develop the complications. And that's an important step that is needed.
Okay, thanks so much. It's now my great pleasure to introduce our next speaker, Amonje Moses, who is Executive Director and founder of Wellness for Greatness Kenya. Wellness for Greatness Kenya is a registered NGO that focuses on public health, public education around physical activity, and also healthy diets, as well as providing cutting edge physical health and fitness services by encouraging positive change to improve the lives and well-being of the Kenyan public from a young age. Amonje is also one of the organizers of today's webinar and a new member of World Obesity Federation. Please go ahead.
Thank you, Johanna. Next slide, please. So thank you, guys, and welcome to this important webinar. My topic today is on childhood obesity and the importance of early intervention, including with schools. Next slide. So obesity, as the professor said, is actually has become a global public health concern. And as she has said that it has many risk factors, it has a risk factor to most non-communicable diseases. And this has implications both of the emotional and physical well-being of the children. The bitter truth is that many children who are overweight and obese at this stage are likely to become overweight and obese at the adult. One of the problems in Africa is that the African culture perceives obesity as a sign of power, which makes obesity look like it's a harmless. Next slide, please. What are the contributing factors to childhood obesity? Number one, there is the issue of unhealthy lifestyles, where we'll talk about unhealthy foods. Globalization and urbanization is another issue, where I'll give one example where real estate developers invade space that can be used for kids as kids play area. There is the issue of physical inactivity, sedentary lifestyles, and issues with the media and technology. Next slide, please. There's a worrying trend from 1975 up to 2016. This research was done in 3 countries, Kenya, Nigeria, and South Africa. I'll focus on South Africa, and it's a research that was done on by looking at boys and girls living with obesity. In 1975, in South Africa, boys who had obesity the rate of obesity was at 1.4%, while in 2016 it was at 20.2%. In girls in South Africa, the rate was at 3.8%, while in 2016 it's at 29.4%. Next slide, please. Generally, you'll realize that in 2016, South Africa, the rate of obesity between the boys and girls is at 24.8%, Nigeria at 8.4%, while Kenya is at 11.1%. So it simply shows that their obesity rate is skyrocketing in Africa. Next slide, please. These are the effects of obesity on the children. It could be health effects and also mental. With regards to the health effects, as the professor said, there is the issue of high blood pressure, breathing problems, type 2 diabetes, and also joint disorders, and it also can lead to some cancers. Next slide, please. The emotional aspect when it comes to children and childhood obesity, and especially those kids who are going to school, it will lead to things like lower life satisfaction. They'll be prone to bullying, lower participation in schools. It will definitely affect the self-esteem and confidence. It will lead to anxiety and depression, and also poor educational performance. Next slide, please. As you can see that from what I've presented, it simply shows that the rates of childhood obesity will continue to rise unless something is done to tackle these obesogenic factors. So what are some of the things that as a population, as a people, as government, as non-governmental organizations, what can we do to handle this situation so as to fight obesity? So our approach is actually by ensuring we target places where kids can be found, and these are schools. Next slide, please. Why are we targeting schools? It's evident that if we reach to children, it's definitely that we'll be able to reach out to their parents, the families, and to the community at large. The school period also covers the period between childhood and adolescence. This is an influential stage where positive behavioral change can be nurtured. Building habits while in schools is also very possible, and also developing skills like participation in physical activity, habits like engaging, making sure they have healthy diets, and also the issue of emotional intelligence, where children will be able to learn on how to deal with stressful situations such as stigma. And children living with obesity are also prone to bullying, so they'll definitely be in a position to be able to learn on how to handle such stigma. Then, in short, schools remain the ideal place to talk about and sensitize on childhood obesity. Next slide, please. What are some of the objectives that this approach will be able to address? Number one, through schools, the children will be able to learn the causes, prevention, and management of obesity. We can be able also to promote the interest and sensitize on matters with obesity. They'll be able not only to participate in physical activity, but also learn what physical activity is. They'll be able to know what are the health diets, and also participate in having healthy diets, both in school and out of school. Through schools, we shall have definitely a coordinated approach. This coordinated approach will have stakeholders, will involve all stakeholders, from parents, teachers, learners, and also non-teaching staff. Next slide, please. So when it comes to these approaches, then through schools, schools can also have different activities to be able to fight obesity in schools. Through schools, we can be able to assess learners who have possible risk factors to overweight and obesity. They can be able to be referred to healthcare providers for further assessment, because obesity is a disease. There's also the issue of school leadership, where teachers and also school administration can be the role models and also encourage healthy lifestyles in schools. Schools can be able to develop individualist plans, including diets and also physical activity assessment programs for learners. Schools can also be able to provide individual counseling and also motivation to learners. Next slide, please. So in conclusion, these are some of the recommendations that as well as for greatness we are proposing and also executing in schools. Number one, we have the CATCH program. The CATCH is a program, it's a curriculum support material that will enhance physical activity in schools. It's a program that will support both physical activity and healthy diet consumption in schools. CATCH simply means coordinated approach to child health. The next one is physical literacy. It's not possible for kids to understand why physical activity is important. So it's definitely very important for them to understand why they should participate, the importance of participating in physical activity, for them to have the motivation and the competence to participate in physical activity. That is what is called the physical literacy. Number three is having school wellness councils, which is a body or a committee that will be set up that should be set up in schools. A body that will have all stakeholders, be it learners, teachers, parents, and also non-teaching staff. People who will be dedicated to ensure that the health of the school is taken care of, both the health of the teachers and the health of the learners. As an organization, we are planning to host the Kenya National Convention on Obesity. We will reach out definitely to the stakeholders who are part of this meeting, so that we can be able to make noise and talk about obesity in Kenya and Africa at large. It's not being talked about, and this is the best time to talk about obesity, because almost all the sectors in the country are being affected by obesity. So this will be the best platform to bring all these stakeholders together and be able to talk about issues with obesity. Next slide, please. So as I conclude, I would like also to sensitize on the issue of the people first language. It's important to make sure that as we engage, as we approach and live with persons living with disability, it's important to know that these people have feelings and they need care and concern. I have never had a situation whereby like a person who's living with diabetes or someone who's living with cancer being referred to as this person is cancerous. So it is not honorable to talk to and refer to people living with obesity like this person is obese. Thank you.
Thank you very much, Moses. That was an excellent presentation. One question came for you in the chat, congratulating you and on this presentation and on the work that you're doing in schools. And it's very reflective of the WHO Ending Childhood Obesity Commission recommendations as well. The question is, how can obesity programs be made sustainable in schools? Do you have any suggestions or ideas for that?
Yes, definitely. One of the approaches that we are using is by making sure that we work with teachers. Teachers will definitely make the best champions for childhood obesity sensitization in schools. And we also engaging learners who will definitely make very good ambassadors in schools. If you look at our approach of having curriculum support materials in schools, it will definitely make sure that this is teachers will be able to learn more ideas and have different strategies on how to engage learners in physical activity. Physical literacy will make them understand the importance of participating in physical activity. When you come to wellness councils, when we have wellness councils or committees in schools that are supporting health in schools, it will definitely ensure that parents are involved, teachers are involved, and also learners are involved in their health. So it will definitely be sustainable by having that in schools.
you very much, and we'll hear more from you later on the panel. Thank you so much. Now it's my great pleasure to introduce our next speaker, Veronica Kirogo, who's Director of the Division of Human Nutrition and Dietetics at the Kenya Ministry of Health. She has vast experience in food security and nutrition programs, both at the policy and community levels in Kenya. And she holds a MSc degree in applied human nutrition at the University of Nairobi. Veronica?
Thank you very much, Johanna, for that introduction. Good evening, good morning, good afternoon, everyone. I'm going to look at share experience on obesity as a priority in Kenya and its impact on COVID-19. But before I tackle on my presentation, just a follow-up on the question that had been asked to previously on how we can be able to have sustainable measures at the school in order to prevent obesity. Currently, we have done included food and nutrition content in the revised school curriculum, where we want children from all the way from grade 1 to be taught on the good, healthy eating. And with that, we are hoping to calculate, good dietary behavior in children, so that as they develop to adulthood, they have good nutrition practices. Next slide, please. So I'm going to quickly look at situation analysis in Kenya in terms of obesity, then drivers for increased consumption of unhealthy diets, and now I'll look at the ongoing intervention by the government, and briefly look at obesity and COVID-19, and then impact and burden of obesity, challenges and recommendation. Next slide, please. So Kenya is located in the East Africa of Africa, as you can see from the map. And we have a population of 47.6 million people as by 2019 census. And in terms of nutrition situation, we are facing triple burden of malnutrition. I know Khaled had said that in Africa, we're having such a, the burden, undernutrition, overnutrition, micronutrient, malnutrition coexisting. We have 1 in every 4 children under 5 who are stunted. At the same time, we have 4% who are obese and overweight. Among the adult population, we are having 28% who are overweight or living with obesity, and 18% are men, and women are more affected with 39% of women being obese. Some of the counties, we are having over 50% of women of reproductive age who are obese. When we look at the dietary behavior, we have only 6% of the population consuming the recommended 5 servings of fruits, of vegetables and fruits per day. Several studies have shown that there's high consumption of unhealthy foods in both rural and urban population in Kenya. A study done in school found that there's high prevalence of ultra-processed and unhealthy snack among school children, and that can be associated to the increase in obesity among adolescents. Next slide, please. So what are the drivers of increased consumption of unhealthy diets, which is also resulting into obesity? One, among the population, there's inadequate knowledge in order to inform decision in food choices. There's also widespread availability and affordability and of convenience and healthy foods. We have, especially in the urban area, fast food cafes are on the rise, and with the working population, finding that it's very easy and less time consuming to indulge in this fast food. We're also having aggressive promotion of processed and ultra processed food products that are high in sugars and fat. Buy one, let's say buy one, get one free. And of course, that's very enticing. And of course, that will end up having increase in the burden of obesity. And of course, time constraint with the urbanization, food selection, food preparation is time consuming. So people, find it is very convenient to go to fast food and unhealthy foods. Next slide, please. So as a government, what are we doing? First of all, the policy environment is very favorable. From our Constitution of Kenya, Article 43 gives every person a right to adequate diet or food. It also gives children the right to basic nutrition. Then we have Kenya Health Policy 2014 to 2030. On the right, you can see those policies, and the National Food and Nutrition Security Policy, speaking on healthy diet or promotion of nutrition along the life course. We also have at the community, we have community health policy where nutrition is an essential intervention. We have the primary health care strategy, and we have the school meal and nutrition strategy, talking on the school meal program. And of course, starting from the 1,000 days, that is from conception to the time the child is 2 years, we want to have very good infant and young child feeding practices. So we have the Breast Milk Substitute Act, which actually regulates the marketing of breast milk substitutes, which have been seen they can be improper feeding practices. Also, we have mandatory legal fortification of salt, packaged maize and wheat flour, and also nutrition labeling standards. Next slide, please. In terms of programmatic approaches, one of the key things we are doing, we are promoting screening, early screening, to ensure early detection of obesity and other conditions, both at the community and facility level. We also have national surveillance. We have the Kenya Demographic and Health Survey that is done five years apart. We did the last one in 2014. Currently, because of COVID, we were not able to do it in 2019, but we're in the process of planning for the survey. We have also nutrition awareness across the life course. We have promotion of healthy diets and physical activity in the population. We have the national guidelines for healthy diet and physical activity, which is what we are promoting. And of course, we are also promoting maternal, infant, and young child nutrition, starting from maternal nutrition, exclusive breastfeeding, all the way to complementary feeding. Another key thing we have done, integration of nutrition content in the revised school curriculum. And of course, knowing this is a multi-sectoral, require multi-sectoral approaches, we are engaging the Ministry of Agriculture, Ministry of Education, Ministry of Social Protection in order to conclusively address issues of malnutrition. We're also having integrated outreaches and health screening. And another thing is the primary health care, where we have nutrition intervention as key essential package in that primary health care. Next slide, please. Under research, currently with Kenyatta University, we support from the International Atomic Energy Agency. We are implementing a nutrition project whose aim is actually to use the stable isotope technique application to measure body composition, and we'll be able to assess the effect of nutrition intervention such as diet and physical activity towards tackling obesity among women of reproductive age. We'll be able to share the findings once the research is done. Next slide, please. Of course, we all know that the world is currently facing COVID-19 pandemic. And of course, with obesity being one of the risk factors for not just NCD, but also for COVID, studies have found that having obesity may triple the risk of hospitalization due to a COVID-19 infection. We have found in studies in US that 30% of adult COVID-19 hospitalization were actually attributed to obesity, and that obesity increases the risk of severe illnesses from COVID-19. And now it was also found that globally 70 to 90% of COVID-19 patients suffering from respiratory failure who were admitted to the intensive care unit were actually overweight. And of course, longer ICU length of stay was observed in a COVID-19 positive patient. In fact, in one of the COVID briefing, our Chief Administrative Secretary brought caution to the people with living with obesity, because what we were experiencing is that people with severe abdominal obesity also have mechanical respiratory problem resulting in poor ventilation of the lungs, that's increasing the risk of pneumonia as well as reduced oxygen saturation of blood. And then with COVID-19, this combination of condition can be deadly. And so that also made the Ministry of Health in Kenya run several messaging in terms of promoting of healthy eating. Next slide, please. So what is the impact and burden of obesity? Of course, the previous speaker have said that major obesity is a major risk factor for NCD. In Kenya, we are having a rising burden of NCD. It is the second leading cause of morbidity and mortality in Kenya. 50% of hospital admission in Kenya are due to NCD. 55% of the hospital deaths are actually due to NCD. And of course, this, knowing that obesity is a risk factor to NCD, then we need to take action. We know that it's also increasing health cost, reduced productivity, social and emotional effects such as discrimination, lower quality of life, susceptibility to depression, stigma, name it. And that's why we need to call for action to address obesity. Next slide, please. So what challenges are we having in Kenya? One of the challenges, as I had said, is inadequate nutrition knowledge among majority of the population. Also low coverage of nutrition awareness campaign and affordability of healthy nutritious diet. Nutrition transition towards diet high in sugar, fats, animal and processed products. Currently, right now, what we are doing, we want to introduce front of pack labeling in all prepackaged food as a way of informing the consumer in terms of helping them on food choices. We're also having easily accessible and affordable and healthy diet, especially in the urban areas. Then aggressive and inappropriate marketing of food products high in calories, salt, sugar, etc. Then of course, we have the changing lifestyle as we urbanize from physically active to sedentary. And what does that mean? Maintaining the same caloric intake leads to obesity. Then we're having a long interval in conducting national surveillance. For instance, KDHS, 5 years is quite long to really see the trend. And in order to, just have intervention that are very swift and addresses the problem. Then also we have inadequate funding for preventive and promotive health services. Next slide, please. So from what I can say from my presented, the recommendation, one thing, enhancing social behavior change through nutrition education. We have seen social media platform are very effective in that. So having messaging that is designed for social media so that we are able to reach wide coverage. Provide incentives for healthy eating habits, including production of healthy foods. It's very important. Then scaling up screening of early detection of obesity and other conditions so that we're able to intervene early enough. Then promotion of strategies to increase the level of physical activity, especially among the urban population. Regulating of marketing of unhealthy food, particularly to the school children. Introducing physical measures targeting unhealthy food product to discourage consumption. I know South Africa has done that. Then improve surveillance and monitoring of the population health. Next slide, please. So I want to just thank you and say this, I think as we mark this day, this is a call of action that we have what it takes to halt and reverse this trend of increasing obesity so that we can reduce the health cost, we can increase productivity of our people, and the world will be a better place to live in. Thank you very much, and back to you, Johanna.
Thank you so much, and fantastic presentation. There were a number of questions, but I want to keep us, we're a couple of minutes behind schedule, and I'm trying to keep us on schedule so we can hear everybody. So we will address them during the later question and answer period. But please do, if you have a chance, look at them in the Q&A section as well, and you're free to respond to them directly. It's now, because it's the year of nutrition, as we know, in the UN system, and the Food System Summit, the big UN meeting is happening in September at the time of the UN General Assembly. It's really important to understand the role of Africa in the Food System Summit and the Food System Summit in terms of its how it relates to obesity and to overall nutrition in the African continent. And it's my great pleasure to introduce our friend, Dr. Francesco Branca, who is Director of the Department of Nutrition and Food Safety at the World Health Organization. He has been at WHO for many years, leading on nutrition, working in the area of NCDs, but also more broadly, leading new nutrition guidelines, working in a variety of areas. And he has been a champion for the recognition of the relationship between overweight and obesity and food systems. So we're very, very pleased to welcome Dr. Branca today. And I think without further ado, I will just ask him to take the floor. Francesco.
Thank you very much, Joanna, and thanks for the invitation to be with you this afternoon. So if I can have my first slide, I really would like to start by reminding that food is such an important element for not only our human health, but also for the animal and ecosystems health. So it's really at the heart of a healthy functioning of our ecosystem. We like to talk about One Health at the moment, and I think food is really at the heart of the One Health approach. There are many ways in which food and food systems can impact health. But by food systems, I really mean not only the food we eat, but the whole process that is producing food, is processing, transporting, and disposing of food. So this food systems, unfortunately, are not functional. They're making us ill with non-communicable diseases, including obesity, but also they're affecting our planet through climate change and reducing biodiversity. And COVID-19 has demonstrated how also vulnerable food systems are. Can I have my next slide, please? The Secretary General of the United Nations has called this year a food system summit, exactly for this. I mean, he realized that in the way to the achievement of the Sustainable Development Goals in the middle of the Decade of Action on Nutrition, we needed to have a focus on transforming food system. He appointed a special envoy, Dr. Agnes Kalibata, and he's called this summit, which is supposed to be a people summit and a solution summit. So an opportunity for everybody from all communities at all levels, from all over the world, to contribute some ideas for change of food systems. The way we have worked on the preparation of food system is to structure along 5 action tracks. Next slide, please. So the food system is going to deal with ensuring access to safe and nutrition for all, to shift to health and sustainable consumption patterns, boosting nature positive production at sufficient scales, advancing equitable livelihoods and value distribution, building resilience to vulnerability, shocks, and stresses. So it's really dealing with health of humans, with the health of the planet, considering healthy food environments, considering production of food, so the One Health approach, considering food loss and waste, and with the idea of having solutions and creating coalitions to implement. Next slide, please. You see there's been a journey which started already last year, and a lot of people have been involved, and many ideas have been collected from people all over the world, more than 2,000 ideas. Of course, they have been then analyzed and assessed for their evidence-based and for their potential impact. So a first group of 100 quality game changers have been identified, and then further going towards the summit, a series of action areas, cross-cutting action areas that would then lead to a set of key galvanizing objective for the change. And we're we're about there. We're about to see a pre-summit in the end of July, and then the summit in September. Next slide, please. WHO believes that there are 6 food system actions that can be a very important set of game changers. And I've heard already several of those mentioned by you today. Fiscal policies for healthy and sustainable diets. I mean, the pricing of food is so important. Public food procurement and service policies for a healthy diet which is sustainably produced. I've heard about schools in Kenya. Nutrition labeling, giving everybody really the opportunity to make their informed choices, but everybody, really people, even young children, even people who are not, who don't have a high literacy rate. And again, I really am happy to hear that Kenya is moving into that direction. Regulation of marketing of foods and non-alcoholic beverages, but also regulating breast milk substitutes. This is still such an important area, and I think we're looking at Kenya really as an example for very progressive, ambitious legislation there. But also food fortification and food product reformulation, aiming at particularly the reduction of salt, sugar, and unhealthy fats in processed food and beverages. Next slide, please. There are many ways for the food system to influence healthy diet, and this is about people's behavior. This is about the food environment. This is about food supply chains which affect our diets in multiple ways and have multiple health outcomes. You mentioned the multiple burdens of malnutrition. The food system and the inefficient food system is affecting those multiple forms simultaneously. But there are really multiple pathways for the food system to influence on health. It's not only about unhealthy diet and food insecurity. It's also about the dissemination of infectious diseases, as we had unfortunately the experience this year again after previous cases. I mean, 75% of the infectious diseases that have become pandemics came from animals, and a lot of them from animals that are used for food, but also antimicrobial resistant depending on the way that animals are grown. Unsafe and adulterated food. The food safety is an important element as well. Environmental contamination and degradation, as well as occupational hazard. So really, food system change is so important for the improvement of our health. Next slide, please. But we're talking about Africa today, and there are multiple challenges in African food system. Unfortunately, per capita food production continues to decline. Farmers have a very hard time. Africa is increasingly relying on imported food. And as you mentioned, that food is high in fat, sugar, and salt. So it's not exactly that food that is supporting healthy diet. We have this unfair pricing system. So smallholders get very little for their product. They have to compete with the relatively cheap imports. We see a shift towards a large retail supermarket mode of food purchasing, which unfortunately is giving a lot of opportunities to ultra processed food. And then productivity is affected negatively by climate change. Next slide. You already heard by at least 2 speakers about the multiple challenges of malnutrition. So it's about obesity, it's about stunting, it's about still wasting in many fragile countries, in many poverty affected countries in Africa. It's still about vitamin and mineral deficiencies. And you know, this is because people have actually moved away from traditional diets with a consumption, higher consumption of sugar, salt, fats, and oils. Next slide, please. What's the response? The response is, of course, acting in multiple sectors, of course, acting in the health system, in social protection, but we do have a major opportunity in food system change. So Food System Summit is an opportunity to turn these trends around. And you know, particularly, I'd like to highlight the proposed Action Track 2 game-changing proposition of the shifting towards the healthy and sustainable diets, and really to create healthy food environment. This is not about people's choice. It's about giving the opportunity of people to access and afford the healthier food choices. 3 billion of people cannot afford the healthy diets. We need to change that. Next slide, please. So what should we do? I mean, this is really an appeal to everybody to get involved, to join country dialogues, to make your voice heard, to contribute to solution clusters, to even organize dialogues in your own countries, to encourage participation, and then to work together. I mean, one of the outcomes of the summit will be to establish coalitions. We're already working with the World Obesity Federation on an obesity coalition. We need to do that and bring as many actors as possible and invite, identify champions, and invite food system champions or the special envoy to come to our events. And then my last slide is really to give you some resources on where to find. If I can maybe have the last slide, the next slide. Thank you. Yeah, this is the series of links where you can find information on the action track, on the summit itself, on the dialogues, on the conveners, and you know, we need to act now with a lot of commitment and all together. Thank you very much.
Thank you so much, Francesco. Excellent presentation. And please, everybody, this is a vote with your feet and ensure that your government, your country, is engaged in the Food System Summit, but also really prioritizing overweight and obesity alongside undernutrition. And we're really looking at malnutrition in all its forms. Francesco, I'm just going to ask you one quick question, which is about, given your experience through ECHO and childhood obesity, what are some ways for both increasing access to healthy foods in schools and decreasing availability of unhealthy foods and beverages? If you could speak a little quickly to that.
This is
2 minutes behind schedule, but
yes, this is the responsibility of the public sector. I mean, the public sector buys food in schools. You can also work with donors who are providing support to school feeding. I mean, you need to have good standards in schools. And then regulations. Food high in fat, sugar, salt should not have a place in schools. And you can use the labeling and you can use the marketing regulation to stop those kind of foods to come into school. And the drinks, you know, get the water, get the clean water in schools, and it will displace the soft drinks.
Great. And if Cristiano Ronaldo is there, he will help you out by moving the Coke can and decreasing Coca-Cola value by 4 billion in one day. But yeah, thank you very much. Excellent. And now we need to move to our next speaker because we are a few minutes behind schedule. It's my great pleasure to introduce Jacqueline Onyengo, who's Senior Deputy Director of the Kenya Institute of Curriculum Development and a trained teacher of physical education. And she'll speak about the role of Kenya's competency-based curriculum in addressing obesity through physical education and nutrition. She also holds a master's degree in curriculum studies from Kenyatta University and University of Nairobi, and has been a technical service person in the Kenya Primary Schools head. So thank you very much, Jacqueline.
Thank you very much, Joanna, and I would like to appreciate all the speakers who have spoken. I think this is an interesting and very useful and important topic. Next slide, please. So I work for the Kenya Institute of Curriculum Development, and we are charged with developing the national curriculum for all the schools from early childhood, primary education, secondary education, and we also deal with teacher education as well as technical and vocational education. Amongst that, we don't leave behind the learners with special needs across the levels. So currently we are undertaking a curriculum reform. The last time we reformed our curriculum was in 1985, so it was really overdue that we needed to make some changes. Next slide, please. So as we do our curriculum, we are conscious of the world around us. We know that we are a nation, and so locally there are certain aspects that need to be sorted out. Regionally, we know we are part of the East African Community Protocol, and there are certain expectations as well. And globally, we know we subscribe to the IBE requirements that we need to undertake curriculum reviewing every 5 years, though we have challenges because of both finances and sometimes just the acceptance of this to be done. But getting back home, our constitution requires that every child should have a compulsory basic education. And we don't just look at education as part of taking them to school, but we need to ensure that they have quality education. And so, as my colleague Veronica did indicate, as an institution, we are serving the nation. And so we work with partners in many ways. And so amongst other things, and just because we are talking about nutrition and health, we partner with all relevant teams, such as the Ministry of Health, as she has indicated. Next slide, please. Now, in this reform, there are certain things that we are holding dear. One of these is the values, and we recognize that sports and physical education give an opportunity for all these values to be played out. And so beyond looking at it in terms of the health factors, we are also looking at a wider spectrum in terms of, are we able to achieve the goals of education that we have underlined? Now in Kenya, we have 8 goals of education, but we also emphasize that we must make sure that our children are growing morally, physically, and spiritually. And so, of course, sports and physical education, and now we have added health and exercise, play an important part. Amongst the guiding principles, you can see that we are seeking towards ensuring every child has an opportunity. Further, that whatever they do, they get excellence in it, and that would include if they are getting into sports. We want to make sure that we appreciate the diverse environments that they are living in, but still be able to include them in the different facets of education. We are encouraging parents to be a part of this process because, like we have said, some of the challenges that we do have are related to poor nutrition, lack of food, and this is where parents come in to make sure that their children are able to be taken care of. But we are also sounding out to the community, and this is why we have community service learning as a key area in the curriculum that we are reforming. And this is because the community plays a very huge part in ensuring that there's moderation in what is done. I like the comment that was made about the public being conscious of even the food that they are eating. And so we are embedding this, that it is everybody's responsibility to make sure this happens across the board. In terms of curriculum, then we want to open up the curriculum so that our children have the necessary exposure, but again, they're able to gain from aspects that we know are being undertaken globally, and I think obesity is one of them. Next slide, please. So we have crafted 7 key competences, and this is in relation to the needs assessment that we carried out. And so we believe that for the Kenyan education system, if these are what we are ensuring our children can achieve, then we would be safe. And I will not go through all of them, but we are looking at aspects like just critical thinking and problem solving. And beyond that, I want to look at self-efficacy. Now, in self-efficacy, we would want to ensure that children begin to understand who they are, what their responsibilities are, and work towards the maximum potential that they need to have. In actual fact, our vision of the curriculum is engaged, empowered, and ethical Kenyan citizen. And our mission is to nurture every learner's potential to make sure that they can achieve the best they can. And we want to believe that since physical education is central to this curriculum, as we shall see in a while, then that enables these children to achieve their potential, but also to be able to understand what the expectations of themselves in terms of taking care of their nutrition and their health are, and to be able to learn. That is why we have learning to learn, that there is always, even as we talk about the challenges that we have, then we need to learn to be adaptable to the different environments so that yes, there may be deficiencies in food, but when we know that there's a deficiency, what is it that we can teach children to be able to help solve that problem so that you can combine the critical thinking, the problem solving, and the learning to learn, because then they know that as citizens, they are able to actually contribute to the Kenyan society. Next slide, please. So this is our new system of education. It is, we are calling it a 2633 system, coming from an 8 years of primary, 4 years of secondary, and 4 years of university education. And so learners are going through progressively from the pre-primary into the senior secondary. But you can see that we have 3 particular cohorts. And the expectation is that as the children progress from pre-primary to lower primary, there are certain aspects we expect them to achieve. The same to middle school, which has 2 facets of upper primary and lower secondary. And finally, as they select their pathways in terms of their careers, we have senior school, and this is where now we have embedded physical education actually as a pathway for the first time in the time that we have had education being run in our country. On the far right with special needs, we are also catering for learners with special needs who are not able to undertake the regular curriculum, and central to them as well. Physical education is part of what they have to do, all of them. Now at this point, allow me to just indicate that physical education was declared compulsory by a presidential decree in 1989. So I think it is activating it that we have actually picked up to ensure that this is being undertaken as was expected. Next slide, please. So I just want to show that, as my colleague Veronica said, in terms of working together, we are conscious of the challenges the country has. And so because education is seen as the avenue where most of the information needs to be passed to the young children, we have then been able to pick up aspects that we believe are going to play a critical role in helping to mitigate this challenge of obesity that we have. Indeed, I think it's in the health policy where by 2009, for example, it was indicated that 25% of part of the population of Kenya were actually in the level of living with obesity. So we need to make sure that we curb this because it may be more accentuated now. So under the pre-primary, we have environmental activities, and this is a combination of the science, home science, and activities that relate around foods and nutrition because they are young, and so we don't want to give them too many subjects. But as we move forward, you can see we have pulled out hygiene and nutrition. This has not been in a curriculum before, and so that tells the kind of emphasis that we have laid on this particular area. Across the board, physical education is a subject that is going to be learned by all the children as it is compulsory. Next slide, please. As we move to middle school then, again, we still are laying the emphasis. We have physical education and health education. So we are saying it's not just about the executing of skills, but then what are the health aspects that children need to be able to learn? And so when we combine this with what we are learning in home science, which would still carry aspects of food and nutrition, then we are continually putting our children in a state where they can really understand the critical aspects that even the Ministry of Health is trying to emphasize so that this is enacted in their real life. Moving forward, we have health education sounded out, and this is for the teenage group between grade 7 and 9. Again, we pulled these out because there are certain aspects that we think are critical, and aspects actually of exercise and health and nutrition are critical here, so that the children continue understanding and learning the basics of what physical education and health are all about. Next slide, please. As we go into secondary education, and this is now senior school, for the first time ever, we have physical education as a pathway where we have arts and sports sciences, we have the social sciences, and we have science and technology. But in the arts and sports pathway, basically we are saying that children are actually going to start taking physical education as an academic area. In the current system, it is only confined to the university education, but we are starting much earlier. And if we can move on to just the next slide, we'll just see what aspects we are looking at. So for a child who is going to take physical education as the area that is their area of interest, and this means that they are not going to do English or science or physics, but they are going to actually take sports, and they are dealing with aspects of clear physical education. But alongside this, then, these children are expected to take subjects like biology, chemistry or physics, so that they can be able to understand some of the careers that they are going into, like sports medicine, will require that they have certain basics. But I think the joy is that we have taken, being a nation that is very well endowed, especially in athletics, we are saying we no longer want to take physical education just for practice, but we want to make sure that it starts as an academic discipline and is going to be undertaken across the board. The essence is that beyond learning the skills, every child in Kenya who has undergone physical education and even is taking the sports pathway as a career line can be able to utilize this in terms of keeping themselves healthy. We know that during leisure time, people will do all sorts of things, and we want that even at that leisure time, people can find it necessary to continually exercise, regardless of the kind of jobs and duties that they have, because it is that exercise that actually keeps us fit beyond eating a healthy diet. Now, we are lucky that I think it was about last week, we did launch our physical education and sports policy for basic education. And this again is a first. We have never had a sports policy in this country. And the purpose is just so that we can embed aspects of health education, aspects of nutrition, aspects of the importance of exercise beyond doing sports, so that we make sure that as a nation, everybody is physically literate and is able to actually take good care of their health, utilizing good nutrition, but at the same time ensuring that we continually do exercise and are involved in sports, because this is what is going to keep us healthy. So as a curriculum center, this is where our concentration is. Thank you very much, because the last slide, I think, is just thanking everybody. Back to you, Johanna.
Okay, thank you, Jacqueline. Thank you so much. There was a couple of questions for you, but I'm going to need to get to the next panel because we're about 7 minutes behind schedule now. But I will ask the earlier speakers to please stay around if you can, and if time permits, we'll be able to have everybody join the panel. I'm going to introduce all of the speakers, give all of their brief bios. They will each give just a very brief summary presentation and then have a dialogue, which will incorporate your questions and answers. So for the four panelists, it's my great pleasure to introduce each one of them. Dr. Kingsley Akinroy is director of the Nigerian Heart Foundation, past vice president of World Heart Federation, and of the African Epidemiological Association, and has published in many peer-reviewed journals. Dr. Catherine Karekezi is a pharmacist profession with PhD in medicinal chemistry, and she's a technical advisor to the NCD Alliance in Kenya, a founder of the Kenya Diabetes Management Information Center, and member of the NCD Child Task Force on Essential Medicines. Dr. Jean-Claude Mbanya is Professor of Medicine and Endocrinology at the Faculty of Medicine and Biomedical Sciences at the University of Yaoundé in Cameroon, and he is consultant physician at the National Obesity Center of the Yaoundé Central Hospital. He's also honorary president of International Diabetes Federation and a fellow of the Royal College of Physicians in London. And Dr. Onyengo Stephen is a non-communicable disease advocate and author known for his vast work in developing programs and innovations and improving NCD literacy. And he can also speak to lived experience. So if you would each unmute yourselves and then go one by one with your presentations. It'll be a great pleasure to hear you, and then we will finish with questions and answers and a dialogue with the panel. Thank you. Kingsley?
Thank you, Joanna, and good afternoon, good morning, good evening to everybody. Thank you to World Obesity Federation for bringing me to this discussion. Quite a lot of ground have been covered. Nigeria also being part of Africa. Next slide, please. The status of obesity in Africa has been covered, and I thank Francesco, Veronica, and all my previous colleagues that really obesity is a silent epidemic in Africa. I moved on to specifically talking about Nigeria. Overweight and obesity are prevalent among primary school learners, and especially in the urban and private schools. In Nigeria, the prevalence of overweight ranges from about 21% to about 35%, while obesity is also about 8 to 22%. Next slide, please. Peculiarly, the silent causes of obesity in Africa, we have mentioned quite a lot, but I will just delve on the increased sedentary behaviors, the increased consumption of pastries, cakes, high sugar containing confectionery and beverages, and more importantly, too, there's limited space for playgrounds and parks for children. Next one. Of course, this has been covered to see that the trends of obesity in Africa is increasing. Of the 41 million children in the world, 25% are living in Africa. And also, under 5, or the children under 5 is also rising. The prevalence very close to 4.7%, which is also lower, a little lower than the global prevalence of 5.6%. Next one. And among the adults in Africa, 18.4% of adult African women have obesity, while also for the children, we can also see this. I also want to mention that, well, what do we do to be able to reverse this trend? A lot of things have been mentioned, but more importantly, I just want to jump to that to say that we need a lot of public education. We need policies, especially policies on food. And part of what has been also been discussed is the homegrown school feeding program, which also needs to be promoted, and food labeling. I just want to say to Francesca that also in Nigeria, we've started food labeling policy, but we hope that also to develop this further. So thank you, and I wait for more questions also during the discussion. Thank you very much.
Thank you very much, Kingsley. Catherine? Say. Dr. Karakesi, yes?
Okay. Thank you very much for the introduction and for the invitation to speak today. I'll just talk about responding to obesity in Kenya from the Non-Communicable Diseases Alliance of Kenya. Next slide, please. Just to introduce the Non-Communicable Disease Alliance of Kenya, this is the national umbrella body of all organizations involved in advocacy, prevention, control, care, and rehabilitation of persons living with or at risk of developing NCDs. I really won't go through the issues of prevalence of obesity in Kenya because most of this has actually been covered today. Apart from pointing out that my statistics is actually wrong, the men should be 17.5%, not 7.5%. And again, there is a disparity between urban and rural areas in terms of obesity, and also the issue of childhood obesity, again, disparity between urban and rural areas. And the fact that obesity has been mentioned as a risk factor for certain NCDs, non-communicable diseases, for example, the cardiovascular type 2 diabetes, and some types of cancer. Next slide, please. Again, looking at obesity in Kenya, I think most of this has been covered. The issue of the nutritional transition in terms of urbanization, globalization, the advances in technology, and income growth. We have discussed the issues of increased processed foods, which tend to be high in calorie, low in fiber, and also do contain toxic chemicals, especially in terms of animal-sourced products. The issue of decreased traditional diets, and these diets really tend to be the natural foods, which are high in fiber and micronutrient rich. There is also the addition of the aspirational value of consuming Western diets. We've already spoken about the issues of malnutrition in terms of overweight and obesity, which is a form of malnutrition, micronutrient deficiency, and the existence of undernutrition and overnutrition in the same populations. Again, the other factor contributing to obesity is the decreased physical activity and increase in activity. And just essentially to say that we are living in an obesogenic urban food environment, and obesity does contribute to metabolic imbalance because of its inflammatory processes, and this is what gives rise to some NCDs. Next slide, please. Now, just to mention how NCD Alliance Kenya is responding to in Kenya, we're advocating for a paradigm shift for non-communicable disease prevention and care, with a major focus on prevention aspects. Food systems change to facilitate equitable access to real food and to minimize processed food-like products with pesticide chemical residues and biological contaminants, which are actually contributing to some of the NCDs that we're seeing in the country. We've also mentioned the aspects of taxation of sugar-sweetened beverages, prohibiting marketing of highly processed and healthy foods to children, and promoting physical activity. And one of the major areas that NCD Alliance is focusing on is to enhance community awareness of the links between unhealthy diets, obesity, and non-communicable diseases. We do face some challenges as we go about our advocacy. Food industry, which is seen by the government as a revenue source, and therefore there's a resistance to try and regulate some aspects of it. And then of course, there is an interference by the food industry, especially when it comes to taxation of some of the highly processed foods. There is also the lack of national consensus on the health risks of sugar-sweetened beverages. In terms of opportunities that NCD Alliance is focusing on, we do have the NCD Interagency Coordinating Committee, and this is a committee of the Ministry of Health, which brings on board the non-health sector. And what this allows us to do is to basically involve them in NCD prevention and control. For example, agriculture, environment, built environment, trade and industry, and so on. What is their contribution to NCD, to the NCD burden in Kenya? And then of course, we are also involved in NCD policy development. And lastly, COVID-19. This has given a big focus on non-communicable diseases and NCDs. And we're leveraging this to try and to prioritize NCDs prevention interventions. Thank you very much for your attention, and we'll be happy to take questions afterwards. Thank you.
Thank you very much. Jean-Claude?
Thank you, Joanna, for this for invitation and for accepting me to be here. I think what I'll do is that I'll just concentrate on the obesity as Francesco and the rest have said. But then I'll go through the relationship between, in our continent, diabetes and obesity. Can I have the first slide, please? I think some of the determinants of, as you see here, of diabetes in sub-Saharan Africa are also the determinants of obesity. And I want to flag one thing up in terms of modifiable factors like urbanization. We have found in Cameroon now, as people move from the rural to the urban area, they tend to put on weight and more obese. We've also heard about physical inactivity in most people, especially those who live in the urban areas. And then some have alluded to nutritional transition, where most people would think that junk food is better than the African food rich in fibers and diet. And of course, we always classify in diabetes as one of the determinants as obesity, and that's why I put it in bold. But most of these, in terms of ethnic origin, age, family history, even with obesity, there are some ethnic structures where you are more obese, where you live, where you come from an ethnic group, and as you get older, you tend to become more obese. Next slide, please. And if I look at this slide, and these are some of the countries we work with in Cameroon, Kenya, Malawi, Nigeria, South Africa, we call it AMPA countries, where we actually look at obesity across the board. You'll see that it averages between 22% in Malawi to 26% in Kenya, and this is male and female, to 33% in Nigeria, and 34% in Cameroon. But you see South Africa, 54%. It seems as if when people embrace economic development, they tend to forget the walking, the bicycles, and every other thing. And the tendency is to get obese. So these are the picture we brought out from this study, that obesity is actually a disease, and that with this disease, and I'm saying here about BMI greater than 25, if we took greater than 30, you would see that by proportionate to the population. And one of the observations we had here was that even in our school children, we've started having more obese children. You just need to look at the children when they're coming out from school or boarding school. You see them like small masses of protoplasm putting on weight, and they carry this obesity through the pubertal age and to adulthood. So there's a flow of this obesity in the young adults of our countries in Africa. So much so that we have started having type 2 diabetes in the adolescents, and the driving force behind type 2 diabetes in the adolescents is obesity. Imagine someone who is obese and has type 2 diabetes at the age of 16. Imagine by the time they reach 40 without the medical care, that they must have complications on their life expectancy. Even in the diabetes population, next slide. If we look at the diabetes population, and I just put these slides up, which is some of the recent work we did in about 12 African countries. If you look at BMI in a class of people with diabetes, and these are the mean values plus or minus standard deviation. If you look at type 1 diabetes, about 25% of them in terms of mean value, BMI is about 25 plus or minus 4. Look at type 2 diabetes only on oral glucose lowering agents. Most of them were 29, BMI of 29%. Those who were on insulin was 28.2%. Those who were on oral drugs plus insulin were about 30%, and a total of about 24%. So we're talking about obesity, diabetes, other NCDs as all leading to the same thing. Obesity being in terms of chronicity and the disease, and crossing across so many other diseases, and the other NCDs influencing very much on this. What have we decided to do in Cameroon? And I didn't put this slide up because I was told I should not go above 3 slides, is that we think that it might be late for you and for me if you have my age, because we cannot change our eating habits, the way we exercise. So we've started with school health in terms of adolescents, children and adolescents, introducing school health programs. So my team has developed the food atlas and trained primary school teachers how to use the atlas and how to train their children. And the net effect we're having is that children have stopped eating their mother's food in the rural areas because, oh, mom, there is too much oil in this food. It will make me to have a disease they call obesity, and finally diabetes, cancer, and the rest. And over time, the parents would be recalcitrant to change. But over time, they change because no mother would want to see the child starve. So it's having an effect, and we're using it in the secondary education and primary education teachers to actually teach them how to transmit the lessons. And we do practical sessions with the children. And I think there will be a policy in Cameroon in terms of physical activity policy for school children, which they have, but it's not effective, and more especially on how to use the food atlas. And then we have also developed portion sizes related to that atlas. And all we're trying to do in a nutshell is to reduce obesity in children, train them how to be more physically active, train them how to eat well, and the types of portion sizes. What we have to work on as an international federation is about built-in environments. In Cameroon and in most African countries, roads are built for people who have cows, not for people who walk on foot, because if you attempt to jog beside the road on the footpath, you'll break your bones because there are so many holes there at the drainage system. So in a nutshell, let's all work together in terms of improving not only our environment, but also our school health and also our adult health, like you've seen in Kenya, so that tomorrow we'll have the next generation of children who are more health conscious than us. And then lastly, let's have a health conscious economic development, not just embracing economic development without thinking of the health consequences of it. Thank you.
Thank you very much. And bueno, Stephen, if you could keep your remarks brief so we can have a few questions and answers. Thank you so much for an excellent presentation.
All right, thank you very much.
Go ahead.
All right, thank you very much, everyone, for very amazing contributions and sessions throughout. And I'd like to probably take 2 minutes and sort of give the patient perspective of obesity, you know, speaking to my lived experience with childhood obesity. So in summary, you know, my name is Stephen, and when I was born overweight, and I got to live overweight for, you know, a very long time in my early childhood. And it is interesting that being born overweight in an African family like mine, you know, you are considered healthy and, you know, you are called king, and the family and the environment protects you. They cuddle you and they make you feel like this is how you're supposed to be. And it's sort of a show of, you know, health and even future wealth, you know, they say. And so, you know, most of my primary school and earlier on when I was living through this, you know, that is what I knew, that, you know, my weight is something good. And so, you know, I could continuously eat, and that will not, you know, show up as that, and they accepted that. And then when I go to, you know, high school, and, you know, in my very first years of high school, what happened is that, you know, some of my classmates for the first time ever, you know, mentioned that, you know, I'm fat, you know, that is what they called me. I'm fat. You know, I need to look strong like all of the other boys. And there's sort of an ideal physique that people are chasing. And for some reason, it was assumed that fat people, you know, fat children like me are lazy, and we come from wealthy backgrounds, and we are, you know, we are endowed and we are healthy. And, you know, that was not the case. And this led to a lot of, you know, stigma and discrimination and isolation. And so, you know, you can imagine at 15 years old, you're seated all alone in the class, at the very front of the class, because you don't want to talk to weight and why, you know, why all of a sudden this weight has become such a huge disadvantage, and you cannot be able to do something about it. And you try to do things about it. You try to get into physical exercise, try to get into sports, and for some time it shows that, you know, results are not forthcoming. And so that has been my experience, you know, earlier on with childhood obesity, and then living through it until, you know, at some point in my second year, I decided to start actively engaging in physical activity, took some radical changes, had a lot of support, you know, and especially mental support with my teachers back in the high school, who acted as both teachers and counselors, and, you know, people who take me through physical activity. And, you know, that led that from me becoming a person living with obesity to, at the end of the story, becoming a champion of obesity, someone who, other children in the community who are born overweight could look up to and say, hey, let's emulate this example, someone who has lived with obesity and now is living healthier and looks healthier. And so, my personal experience and to the human story behind all of the numbers and all of the statistics that we've talked about, and the importance of this conversation happening, and in Africa where being a good thing is considered a healthy thing. It's important that these conversations happen. And today I just wanted to share a bit of that personal experience and connect to the fact that more of these conversations need to start happening, and we need to start changing the narrative when it comes to obesity. We need to start increasing that literacy. And then also physical education has been talked about, but also the third thing that I'll probably conclude with is and this is a challenge that I'll throw to all of us out there, is that we already know that there is unhealthy food, and there is a lot of unhealthy foods that are competing very highly, and aggressive marketing is how can we make healthy food cool again, so that us as young people and the community begins to see healthy foods as the cool foods to eat, because now that spot is currently being held by a lot of these unhealthy foods. So how can we begin also, from with all of the knowledge and intellect and the power that we have in this panel, start to have conversations around making healthy food cool, so that then we're able to change that narrative as well. And with that, thank you very much. And
thank you so much. And I apologize. I know a couple of our panelists need to leave because we are at time for this presentation. However, we are going to go over by at least 5 minutes, because I think we want to hear from some of our panelists. So we've heard a lot about sort of that food will be key, and then we've heard on the other hand that this is a disease for which other forms of treatment, that we need medicine and surgery. However, those are costly. How do we balance the opportunity, first of all, to introduce to have stronger emphasis on nutrition and physical activity in primary care in the health system, which is one of the things that both diabetes and obesity actually offer, but also to seek opportunities when needed to try to build access to treatments that work, but that are perhaps cost prohibitive in many parts of the world. Does anyone have an opinion on that or a view on that? It's a complex question. There's no one particular answer.
Joanna, I think when I was much younger, like my first study.
I've known you a long time.
my first study in Cameroon was to look at socioeconomic status and obesity, and to our greatest surprise, those with the greatest obesity were those in the lower socioeconomic culture of Yaoundé, because they drank a lot, they ate anything they saw, whereas the people who were rich were actually more active. So to me, what we have to do is to make sure that we promote the African diet, which is actually the good diet, because there's a lot of, the enemy of the good has become the accepted in our society, where you need a hamburger instead of having ugali like corn or corn chaff or anything. So we have to go back to the roots and produce enough data as scientists in order to convince our people that the African diet is the real diet, and that you don't need to import dyes, fat, in sugar, anything else. So that is it. And then secondly, building our cities in such a way that can promulgate physical activity, just working. Because working along Yaoundé, where I live, you'll be knocked down by cars and motorbikes rather than exercising. So people are scared to run. And as I mentioned in my piece, that investing in our children, the next generation, is where we should really start. because the next generation might change things, but some of us are too old, like Kingsley. There's nothing more he can do. Thank you.
Kingsley, since you've been insulted here, do you want to answer? Do you have a different reflection? I'm just teasing.
Well, my friend Gina has brought me in, but I feel one area that we really still need to do is in the area of education. Education can never be enough. There's still a lot of gap that needs to be filled. Not only education within the walls, but also even the education of the people that are policymakers. They need to be educated. We need to bring them nearer and to let them know the importance. Obesity still is best changed language in Africa. Like my friend Stephen mentioned, is still very, very far. So we need to do a lot of education. We need to work with the policymakers, and the policymakers is across all the boards, from the local government level to the highest level. And then we are going to make a difference. Thank you very much.
Fantastic, thank you. There was a couple of questions about very much about social preference for a heavier being overweight. I think it varies a lot. I think it's changing a lot in many African countries, but I have to say I had not heard until today about fattening camps, which was something that apparently was existing in Mauritania. But that even sometimes there's a preference for a heavier weight among children of African immigrants to Europe or to Australia, other places. Do you have any views on that, on how you can communicate the importance of addressing obesity and attempting to be at a healthier weight when working with a family or an individual who has a preference for being at a higher weight?
Joanna, in Africa, it's said that fat is beautiful. In fact, in my region, when a lady gives birth, they put her in a fattening room and then feed her and feed her and feed her up to the child is grown. That is the African tradition, that fat is beautiful. And then the heavier the ladies, the more the men like their ladies heavy. They don't like them very light. I don't know why, don't ask me. That's what people saying it. So I think education, using cultural norms, cultural adaptive information, and using the data from those misconceptions are very important. But also we have to train the healthcare providers. We treat disease, we don't treat people. So somebody, and most of them don't even realize that obesity is a disease. So when someone comes in the clinic, they say, oh, you look healthy. They look healthy because they're obese, they're put on weight. So we should say, oh, you've put on weight. Maybe it can lead to diabetes, to high blood pressure. It's also a disease for cancer. Can I take your BMI, or can you do something about it? So our general approach, one at the clinics and two in our cultural settings, must have to change, because we need to educate our people that these misconceptions, a misnomer that fat is beautiful is not.
Yeah, and I think I'd probably want to add on that almost with a short statement that whilst you might be selling, fat or being with weight as beautiful in the African context, I think the messaging needs to change that, then people are able to choose between being beautiful and being healthy. And if fat is, communicated now as not being healthy, then that, the messaging around, the perception then begins to change. So we need to start to change the messaging towards, being fat could lead you to having these diseases. So it might not be the beautiful way to go. So, that change of messaging, I think, is also something that needs to come out now more strongly.
Great. A couple more questions. One I'm going to direct at Francesco, which is, I hope, Francesco, are you still there? Yes, great. Is about what are your views of the African diet being the key? I don't know that there's one single diet in Africa, but it's a very big continent. But there may be, but just the indigenous, maybe just the local diet.
The quality of the African diet compared. Is that your question?
My question is about, well, I mean, I guess I'm not sure. In your experiences, are you seeing that there is an African diet, but But mainly, do you believe
Yeah.
that the local diet is the key?
Yeah, I mean, there was a very interesting analysis done a couple of years ago by FAO in which they were looking at the food-based dietary guidelines in Africa, and those seem to be very healthy, diets. There's a variety of diets, and there are some traditional diets which are very high in staples, and basically carbohydrates with not necessarily high fiber, and there's more variety. So definitely there's a reality of the African diet that we need to consider. So while in principle, certain traditional diets are good and perfectly in line with the healthy diet guidelines, the practice is that unfortunately we have challenges. And on the one hand, we have diets with poor variety and diets high in simple carbohydrates and also low in animal source food. And on the other hand, we have this transition that it's doesn't go through a healthy diet necessarily, but it goes through to a high consumption of ultra processed food, high in fat, sugar, and salt. I mean, there are some missing elements, and one of them is fruit and vegetables. Meaning the availability of fruit and vegetables in Africa is actually low, insufficient. I mean, it seems a paradox, but it's low. Affordability of those products is often low. So let's say that the diet in principle is an excellent, or could be an excellent diet, but what we are seeing is unfortunately not very good. Of course, if you look at then certain countries, particularly such as Northern African countries or South Africa, you have even increasing challenges because Northern Africa, for example, you have very high consumption of sugar and sugar sweetened beverages. In South Africa, you have very high consumption of meat, for example, and so there's a large variety in the region about the quality of that. But in principle, certain African dietary patterns are very good.
But Francesco, I think the problem is how these are prepared, because they might be very good, but in the preparation process, they have destroyed all the micronutrients and everything. Absolutely. And they've added some lots of oil and the rest, which does not reflect in the African diet as we know it when I was young. I used to eat, when I was young, we ate rice only once a year at Christmas.
Interesting, yeah. Great. Ogweno, I thought you spoke very poignantly about stigma. And I'm curious as to the stigma you experienced as a child. And do you see this as pretty common, or do you see stigma? How do you see stigma, particularly towards it being a factor that makes it hard for people with obesity to seek help or to get help, and including can be stigma sometimes from healthcare providers who don't know?
Because it's two-sided. So. Stigma in itself, once you have weight and once you are overweight, then it's a very common practice, and especially among in the teenage years. When you're in the teenage years, that is when stigma for weight, from my experience and from what I've seen from other young people, is at the highest, because during that age period, there is a need to sort of look a particular kind of way, and there's a particular way that is kind of looking cool, and everybody wants to achieve that ideal fact, and there's a lot of all of this peer pressure. So especially among teenagers, stigma is very high, and it's a very common practice for overweight. You see people living with obesity are not included in activities, in sports. They are considered lazy. These are people who do not contribute. That is the perception. So this kind of stigma is, and especially during teenage years, is a huge thing. The interesting thing, however, is that when you become an adult and you are overweight, then for some reason it changes. The stigma sort of disappears, and overweight is again considered as something good. You are considered as someone healthy and wealthy, especially wealthy. It's almost that people who are fat are considered wealthy people, and it's almost a wealth status symbol. everybody who gets to work, to the workforce wants to be fat fast so that, that is considered healthy. So there is this very unique sort of dynamic with stigma and obesity, but especially among young people in years and up to early adulthood. It's a lot, and I feel like there's still a lot of education that needs to happen, particularly on obesity stigma in itself, and especially amongst this age group. And we need to see positive imaging as well, when it comes to obesity, because even the newspapers or even, most of the books, when they illustrate lazy people, all of them are usually fat people. And I noticed these, in my books earlier on, and started to question that. So again, the imaging even on obesity has, for a very long time has been, depicted very negatively in a way that stigmatizes people living with obesity, so that the imaging in itself contributes again very highly to the stigma that comes with obesity as well. So I feel like this is a strong area that needs a lot of focus on, and especially among the teen years. But when it comes to the adult years, then there needs to be a shift again in educating on the weight and its implications on health, so that then we're able to change that other narrative as well. So yeah, thank you.
Thank you so much. I think we really are running out of time here, but I do want to also acknowledge that we had some very interesting presentations in the last panel, and sort of it's not just obesity, it's obesity and heart disease, obesity and diabetes, obesity and many sort of comorbidities, chronic conditions associated with it. Catherine, I think, raised some important points. And Catherine, if you're still there, I'd love to ask you one final question. Another can jump in as well.
She's gone.
She's gone. Okay, she's left. All right. And Moses, are you still there? You're here. How do you see? So, it's good to see you. How do you see sort of opportunities to fight on two fronts, to be addressing obesity in relation, not just as its own issue, but also in relation to other NCDs? Do you see that as essential do you see that as a promising pathway in Africa?
Yes, definitely. One of the things and that has come out very clear that obesity is a risk factor for most of these non-communicable diseases.
Yeah.
And the fact that when a kid is overweight or obese at his tender age, he's highly likely to be obese and overweight at his adulthood. So that's why, and if we allow the kids to grow and be obese at the adulthood, that's when they'll be able to get these non-communicable diseases. So the earlier we approach this issue, the better. And that's why our approach of addressing the issues to do with the childhood obesity through schools is very important. Like, for example, I'll give an example of physical activity. Where did we go wrong? Physical activity used to happen in schools, but it stopped happening in schools. One of the things is that physical activity used to be used like it's like a form of punishment. You do something wrong, you're told to run. You do something wrong, you're told to do sit-ups. So there is that negativity when it came to physical activity, because when a learner is seen jogging or rather running in the field, he's being stigmatized that boy or that girl did something wrong. So it became a problem. It became a problem, and that's why even kids nowadays don't want to engage in physical activity. Yeah.
Catherine, you're still on the call, is that right?
Yes, I'm still here.
Hi. Did you want to say anything or just about the? I mean, your work is very much obesity as a cross-cutting issue. Did you want to say anything about the opportunities and the challenges there?
I think we're mainly approaching it from the NCD perspective as a risk factor. And as I mentioned, just making the linkage between obesity and NCDs and the linkage of unhealthy diets to obesity. And then also trying to, I think Kingsley also mentioned the issue of creating awareness amongst policymakers. For example, the issue of not understanding those linkages, and also working with the non-health sector to basically, short of saying teach them, make them aware of what their role is in contributing to NCDs. Because as we say, health is dealing with the failures of the other sectors. That's where NCDs come in, from agriculture, from poor environments, from industry influences. So that is a kind of approach that we are trying to take. and are trying to work across sectors.
Absolutely. So I'm just going to need to wrap up now. I did want to note on an make an observation here. Brenda Chitindi is on the on the webinar as well, and she's somebody I know from tobacco control days, and there are a number. She's from Zambia. A number of people working on the African continent have probably in a way recognized that the role that tobacco was playing in NCDs is now being played by obesity in terms of being this one common driver for many, many challenges. And so we need to also support those places like Zambia where they're certainly suffering from significant challenges with overweight and obesity now. So I wanted to really thank everybody and just make a few conclusions that I think we all recognize that obesity is both about prevention and about treatment, disease, and risk for other diseases. Very much an emerging challenge. I think we heard a lot of commonalities, but also some differences. And so there are many opportunities, I think, to work together. And again, with our colleagues in the NCD space who are already doing this. I know that Kingsley and his colleagues in Nigeria are working with World Heart Federation, and World Heart Federation is emphasizing obesity this year. Many other disease areas or risk factor areas are focused on obesity this year. And it is the year of nutrition, and therefore a heavy focus on what we can do to address and improve the food systems is key. Please send great ideas to us, and please reach out to your governments and just, demand, that they have strong presence and action as part of the Food Systems Summit, and know that really the key will be all the opportunities for collaboration and action after the Food Systems Summit. Again, that takes place in September. So this is a both and disease. It's a both childhood and an adult disease. It's both a risk and a treatment issue. There are many, many, many parallels. And so we look forward very much to collaborating with all of you. I think the questions have been fantastic. And I'm very sorry we were not able to address each one individually. But what we will do is get written responses to each of those and send those out as part of the follow-up to this. You will receive slides from this presentation, a recording of the presentation, a certificate of attendance. And here, if you want to learn more, the Global Obesity Observatory is the source of obesity data for World Obesity Federation. So it's on our website, and here it is, data.worldobesity.org. And that I will really highly recommend to you. It's incredibly detailed and it's very easy to use. I have an easy time using it. And if I have an easy time using it, anybody can use it. We have details about our members if you want to get in touch with each other. If you're not a member yet and you'd like to join, please reach out to us. And registering with us, please contact us through membership@worldobesity.org. And then we have, of course, as was mentioned, one of the reasons there's been greater focus on obesity this year is because of COVID. Because as we found out in our World Obesity Day study was that the top 10 countries have for complications of and mortality from COVID, 9 of those had very high obesity rates, including the US and the UK. And similarly, it was a high correlation between the countries with low rates of COVID death also had low rates of obesity. So very clearly, it's much more on people's minds. It's indeed now part of pandemic preparedness. And in fact, having a severe obesity, if and when there is a next pandemic, those with severe obesity will almost certainly be at very high risk for complications and mortality. So we have details, we have a dossier and a number of resources on COVID on our website. We can also direct you to fantastic resources carried by our members in our network. And we have a new e-learning module on COVID-19 and obesity. SCOPE is our training program. And you are welcome to join up, register, and take that. It's a short, very detailed and excellent e-learning module. So those are just some of the resources. I thank you very much for joining today. I thank you very much for taking quite a bit of time out of your busy, busy schedules. I think we all could stay here forever, but we all have work to do. So thanks again. Merci beaucoup. Very much appreciate this. And I hope that this is the beginning of something certainly and not very much not the end of something. I think we will continue to be working together for a long time to come. Thank you very much, everybody. Great thanks to all of you.
Bye-bye.
Really appreciate it. Thank you. Thank you.
Asante sana.
Okay, bye-bye.